PSA only suppressed. So those people, we invariably, once the continence comes down, the urinary control comes, we'll ask for radiation.
So after radiation, can be cold or
After radiation,
can the
so in that there is other classification. So most of the people undergoing sand surgery require radiation and hormone. So more than 70 to 80% of the people will be still in the curative stage of purity. Only 5% or above will have disease somewhere in the body.
I am Shanmugam. I am a retired Air Force officer, and I do not know, I know about all diseases because in the Air Force every year they will check you from head to foot. But this disease I never knew till I retired. Even after retirement I do not know. Then somewhere I read about this. Then I went and checked up. At that time it was 35 points. So then I consulted my friends and people. They said you go to Ayurveda, they will give you some kashayam. With that it will be over.
What age?
That is around 70, I think. I am now 80. So I took that advice and went and had that kashayam and all. Then one fine morning somebody said, what are you doing? You go to an allologist doctor. Then I searched for doctors. Then there were two types of doctors. One is who do the open surgery, and another is like this Curie, where they do it this time. So I found Dr. Krishnan to be the best doctor available in this field and area. Then I came to him in the year 1917, not 1917, what is this year? 80,
10 years back.
not 10 years back.
2018.
2018 I was operated. 2017 I came to him. Then I told him that Ayurveda medicine and all he laughed. He said, I was a gazetted officer and up to a rank of air commodore. For the people who are not aware of this air commodore business, in Tamil Nadu there are 4 or 5 air force stations: Avadi, Tamaram, Tanjavur, Coimbatore, Sulur. All these air force stations are headed by an air commodore. He is the boss. So that was the rank I was, and still unaware of this particular disease, while all other cancers, mouth, kodal, இது எல்லாத்த பத்தியும் படிச்சிருக்கேன். ஆனா இந்த வியாதியை பத்தி ஒண்ணுமே தெரியாது. Okay, anyway, coming back to this, then when I came to Ananda Krishnan, they checked up and found it was about 35. So he said, okay, let us carry out a test and all. Then he suggested that we undergo surgery, which he did on 22nd January 1980. 2018. So he said, after the surgery, I will give you 10 years. You will live for 10 years. I said, okay, that is more than sufficient. Now 18, 19, 20, 21, 22, our 5 years are over. And I come to him once in 3 months after checking the PSA count. So initially he was administrating some injections and things like that. After some time he stopped all that. Now I am not on any of those things. Now I was not here in the country for the last 6-7 months. So I have come now. Today I have given the blood for the PSA. And I am comfortable, I feel all right. I feel I am completely cured. I got no other. At the age of 80 I could do everything. Walking, whatever. So, anything else you want to ask me?
What's the PSA reading? What's the percent reading? PSA reading.
Reading.
PSA.
It was some, what was it? 0.2 or something. Not even 2, it is less than that. Now it may be more because about 6-7 months I had not checked and I was not here to do any physical this thing and all, except some walking and all. And I am very comfortable. I don't feel that I had this injection, this thing. So, any other thing you want to know for me?
We are from Somalia. So my father he lived in Somalia. Luckily, my father he made 2 surgeries here in India in January. 2017 was colon cancer. And he's very clean now. He doesn't have that. And 2019 it was again prostate cancer. And we met Dr. Anata. It's very difficult to pronounce, but it is very good, and we get very hospitality with Rami. So we made the surgery in 2019. We went back home Somalia, and you have to be very lucky because in India there is a lot of facility. You have the technician, the doctors who has very knowledge. In our country, my father when he did BSA test, it shows 7, 6, 8, 9, and when it become 11, my father is saying, oh now maybe all, the cancer is all the body. And you cannot imagine how money we pay to come to here in this hospital. Say around $7,000 to come here in India for us. So when we came here, first BSA test, it was 0.016. For me, I got little knowledge because of my father's problem, so I have to Google every time I ask Professor Google, all information 0.016. And the last time was 11 in Somalia. I became happy because it was 0.016, and I became sad because of our country. They couldn't show us the real BSA test. But now we make MRI, now CT scan, and everything is clean now. And he has the last BSA test was 0.010. So we are very happy to be here actually. And nice to meet you.
Syndrome. There's a mutation in BRCA and MLL gene where you have a colonic cancer, you can have renal and also prostate cancer. I'm going to tell you one trial now. So chances are there, but we don't know which come first. The problem with the prostate is age-related problems also will show in the same way. Prostate cancer also will show in the same way. So same normal age-related prostate enlargement can happen. In the same prostate cancer cell also can be there. Whereas in any other cancer, particularly in the motion passage, blood will be there in the motion. Some diarrhea, tenesmus will be there. Hemoglobin will be dropped. So there are some factors where you can pick up early. Prostate cancer, unless if you come and if I do a pathological examination and see how is the surface, how is the PSA, is there any UTI, urinary infection is there or not, because the prostate infection also can raise the PSA. So all these things it will take cumbersome time to diagnose the prostate cancer. Whereas in colon cancer, blood is there in the thing, hemoglobin is there, do a colonoscopy, take a biopsy, or do a colonoscopy. So we cannot say which is come first, but there is a relation.
So my question is whether they failed to diagnose the prostate cancer first because of that colon.
No, that time we said the PSA is less than 4, less than 3 or 2. So definitely they would have checked. I think in India,
in 2017, when it was the colon cancer problem, the BSA was also high. But in that time, prostate cancer was not priority for us. You know, it was second priority. The first priority was to the colon because he couldn't eat nothing. Do you know colon cancer? It means he cannot contribution, not eating. Everything was
so just you know that there are 2 cancers in the body.
No, we didn't know that. If I know that, I would make the same surgery on the, when I was in the hospital, all the package. But I didn't know that, And it was very weak because of.
I know. First you need to give priority to colon only.
Yeah.
It is more aggressive.
Yeah.
Can I start that? So, should all men get the screen, or who should be offered screening? So this is the question. whether we should screen everyone or only some people should be screened. Why? Because in prostate cancer, there is a term called overdiagnosis. No other cancer, even the breast is now, breast cancer. The prostate cancer, there is a term called overdiagnosis. What is overdiagnosis? Because most of the patients, particularly above 60, 70 years, they can develop this malignancy. They can develop this malignancy inside the prostate, but all the patients may not be having a significant amount of cancer to cause trouble in their lifetime. So underline the lifetime. Each lifetime is different. One will live up to 80 years, one will live up to 85, one will live up to 70, 75. So what they say is, why all this PSA screening we should not do, we should not do, because the literature and some trials which they have conducted shows that we are unnecessarily diagnosing some prostate cancer and we are over-treating them, which may not be required in their lifetime. So just to prevent that morbidity, there is a thing called, now I'll tell you what. So this is the questions now. Should all men be screened? And who should be offered screening? These questions I'll tell you at the end of the presentation. Next. So there is an increase in incidence of severe prostate now. Why? Because there is increased life expectancy. All people, now the life expectancy is improved. And there is more awareness. Everybody is started knowing what is prostate cancer, because all the checkups now, master checkups are including prostate cancer screening now. So all the men above, they're increasing prostate cancer. Females, they're putting pap smear and CA125. So there is aggressive PSA testing. And we got to know what is the genetic cause. So if father is having, son now itself we are preparing to see whether there is any cause in genetics. So there are environmental causes, smoking, mild hypertension. These are very, very, very close, minutely linked towards the, and there are lifestyle issues. Lifestyle issues are not yet proven, but alcohol can cause. But that is very, very minute. This is not significant enough to say that this is the one which is causing. So in 1987, this is the first journal, this is the New England Journal of Medicine. They have tested PSA for the first time in 1987, and they found to have that the prostate cancer, when compared to the PSA testing, both are having relation. Prostate cancer and PSA are found to have relation. That time they tested two things. One is a PSA, one is a prostate acid phosphatase, PAP. But that didn't come into the picture because of those fallacies. It is not as sensitive as PSA. But PSA is sensitive, and they concluded that it is very sensitive in picking up prostate cancers in 1987. Next. So in 1991, so they first this coming to the picture. This showed both PSA and per-rectal examination. We always do this per-rectal examination. Motion for padila we'll see. Motion for padila kai vechi paapom illaya. We'll see how is the prostate, the surface eppadi irukku, smooth irukka, hard irukka, enlargement oru lobe irukka, rendu lobe irukka, idella paakrom illaya. So what they concluded is, age we need to do both PSA and per-rectal examination, so that both of them, when they combine both the physical examination and PSA, chances of detecting the prostate cancer is much higher than PSA as a single test. So rendu combine pannuம்போது sensitivity அதிகமா இருக்கு. ஒரு PSA மட்டும் பண்ணா அவ்வளவு sensitivity வரல. So this they have diagnosed they have come to know in 1991. So from all these years, from 1991 to till now, PSA testing has a ebb and flow. Ebb and flow na waves மாதிரி. மேல இருக்கு கீழ போயிருக்கு screening வந்து, because there are a lot of fallacies and some things, some trials showed some false results. That's why we stopped in between. அதுக்கப்புறம் திருப்பி we picked up again, because that for the results and stop பண்ணனால what has been result வந்து we have study came up. Next. So these two other studies. One is the PLCO study, which is done in 1993. Both these studies started simultaneously. One is the Europe மொத்தமே பண்ணிருக்காங்க. Entire Europe they did one study called European randomized study of screening of prostate cancer. This is called as ESRPC. So one trial called as PLCO, PLCO. So they studied prostate, lung, and colorectal, ovarian. Whether we should screen these patients before. Munadiye screen pannittu appo vandu is there any munadiye screen pannadnala there is any advantage on the 4 cancer lo they studied. This is done in USA, this is done in Europe. Okay, next. After 1993 when they started doing the study, for 10 years one is a 13-year follow, one is a 9-year follow. So they came with the results. What they basically did is, if 100 people irundarna, 50 people they kept in one group where yearly PSA, yearly parental examination pannom. In the 50 people they have not screened. They just left them like that. Whenever there is any symptom, they came for screening. In the 50 people they came for periodic checkup. So this is how they segregated 2 set of people and they studied their follow-up. Is there any change in the complaints? So they published one more follow-up studies. Next. So this is a comparing. So what they did is, the PLC was studied in United States, no? What they did is the chance of diagnosing prostate cancer screening was only 17%. But in the Europe, they got up to 39%. And what is the outcome? On the United States study over there is no significant difference. Munadi screen pannadana there is no difference in number. But in the European study, there is 20% reduction in prostate cancer death, which is very significant. And why this happened? Because there is a lot of cross-contamination in American study. Cross-contamination enna irukana, so the people who are there in the 50%, 2 groups separate pannidhum, who are there in normal, who are there in not doing any test, and the group they came and did a screening or PSAT and DRE outside, apart from that. So they didn't adhere to the protocol. So there is a lot of cross-contamination happened in PLCO group. Next. So after 13 years of follow-up, so the contamination in PLCO group is around 52%. 50% of people who was died, 76,000 level, 50% of people they cross-contaminated. Some people didn't come for follow-up for PSA or DRE. Some people who are there in just usual care, not checking everything, they came into this thing and they got checked. So United States studies there is no that clear adherence to protocol. Europe they followed the proper norms and they did that. So when we compare these 2 studies, European study is having more good data when compared to the PLCO. So that will tell you what. Next. So conclusion, in 2010 when they published this, there's one more study called Gothenburg study. This is done in Sweden. Sweden they have done.
This is the city I live.
Where you live? Gothenburg. So they did a screening. So what they did is, our age group, suppose 1930 to 1940 they had taken the birth registry. And the 10 years yaradu parandukaro avarku they included these people in the study and they did this study. So adula they did a follow-up also. What they concluded is the prostate cancer mortality was reduced almost by half over 14 years of follow-up. However, the risk of over-diagnosis, over-treatment is substantial and the number needed to treat is at least as high as the breast cancer screening. So if you want to treat a small set of people who requires this procedure, who requires the prostate cancer treatment, the significant diagnosis of a cancer is there only in 5 people. But this many people has to get screened. This many people needs to undergo MRI or PET if required in case PSA is elevated. So we are spending so much time, so much resources here to diagnose only 3 or 4 people. But still they say it is worth. Next. So are we saying right by PSA screening or pushing towards over-diagnosis or over-treatment? So we're in 2012, there is a dilemma. So all the guidelines, especially American Urology Association guidelines, European Urology Association, NCCN guidelines, all they started changing their PSA whether to screen or not. Next. So this is called as the United States Preventive Services Task Force. This is the one which regulates screening, vaccination, ellame undu. So they recommended PSA testing as grade D recommendation. In the 2012 study they stopped the PSA testing to routinely done in outpatient basis. 2012 America they stopped PSA testing because they felt that we are over treating, the resources are getting wasted, and they stop because of PLCO, trialcylic. They don't know that cross contamination happened as much. Next. Next. So in all the local newspapers, this is the thing. So whether we are doing right or not, you are just no longer support routine cancer testing. So all these guidelines came when the American guidelines changed not to do a routine PSA testing. So in 2018, so you can see when there is a PSA surge, most of the cancers are diagnosed, and the PSA testing has stopped in 2011 and 2012. The cancer incidence came down. The number of people who are diagnosed with prostate cancer came down because there is no routine PSA testing. Routine test because of the American guidelines changed. Lot of countries also they started changing our guidelines. Till now in India, we don't have guidelines. We still follow American guidelines or we'll follow European guidelines. That is one problem. Next. So 5 years of rethinking. Between 2012 and 2017, did we do wrong by stopping PSA? So this is the one. It got published in 2017 in Nature Review. Next. So what happened is, when they see PSA screening stop on it, when they see the database, whether what happened because we stopped the PSA screening, so there is increase in an increase in prostate cancer incidence because we have stopped testing PSA. There is an increase in distant stage prostate cancer. So there are patients who are getting diagnosed. When they came for diagnosis, ordinarily it is stage 3 or stage 4 cancer. They are not coming in early stage. So patients increase in distant stage prostate cancer in 75 years of age, increase in metastatic disease. By the time when they came to the hospital, they are having bone pain, back pain, because it already spread to other. And there is 36,000 to 57,000 additional prostate cancer deaths. The 5 years of testing stop on the Nala, so the death rate because of the prostate cancer increase. There is a 2-fold increase in stage 4 cancers. So people who got diagnosed or who came to the hospital, they came in very late stages where they had all these issues. So then again, lot of articles published in 2015, 2016, whether we are doing correctly or we should start testing again. So all this impact, what is the impact of stopping PSA, so all this journals also published apart from Nature Review. Next. So this PLCO I told you, so then in 2012, 2017 there are highlights of contamination control law which caused evaluating the PSA testing again in PLCO trial. So when they found that there is a lot of cross contamination, then they changed the recommendation from grade D to grade C now. So what they provide now is, you have to undergo PSA testing. You can offer PSA testing to the patient, but you should tell them what is advantages and what is disadvantages. From grade D recommendation to grade C recommendation 2018. Next. So why it got changed? 13 years of update of ESRPC trial, high contamination PLCO trial, concerns of stage migration. So people who are coming in early stage, now they are coming in locally advanced stage or higher stages. And there is a proven oncological safety in active surveillance. Active surveillance is if the prostate cancer has been diagnosed, prostate cancer can tell, but it is a localized, low risk. It is there in the prostate cancer only, prostate organ only, but other one very low risk. Low risk PSA வந்து ரொம்ப கம்மியா இருக்கு. Gleason grade சொல்றோம் இல்லையா? Gleason grade 3+3 is 6. And the clinical stage one it is only T1A, T1B. So very small indolent cancer then we will keep the patient in active surveillance. Active surveillance they will come 6 monthly to hospital. We know they are having cancer, but we won't treat them. அவசரமா treat பண்ண மாட்டோம். We'll just see the disease whether it is progressing to any significant cancer or not. Why? To avoid morbidity of surgery. Why? To avoid the urinary incontinence, to avoid the erectile dysfunction. So if we give some time to these people, if it is increasing, when we are following up this patient sequentially for 6 months, we are doing colorectal examination, PSA. yearly once MRI scan பண்ணிட்டு if it is increasing, particularly in low risk people, increase ஆகுதுன்னா அப்போ we actively bring the patient into the active treatment. அப்போ வந்து radiation surgery options கொடுத்துட்டு let the patient decide ன்னு சொல்லுவோம். So that period where the patient is curable and still we are just waiting on him because the disease is very low, indolent, less aggressive cancer. So that stage is called as active surveillance. So there is a proven oncological benefit. So patients who are on active surveillance also, they are happy. When they come to the stage where they require procedure, they are as good as the patient who has undergone surgery before. So there is no others. You will not wait for another cancer didn't go anywhere. So there is a proven oncological outcome. So that's why all these things based on the recommendation change from D to C. So now what is the present thing? Should I do 60-year-old? Do I need to get any other test or PSA done? 2012 the guidance shows we should not do. Now that the guidance shows yes, you can do, but you need to understand whether it is, what are the harms and benefits, whether overdiagnosis is the part or not. Next. Yeah, so this is the one which in 2018, all the other trials, PLCO, ERPSPC, the Gordon trial, everything, they concluded that PSA screening may reduce prostate cancer mortality, but it is associated with overdiagnosis and overtreatment. Compared with conservative approach, without doing anything, active treatment for screen detected prostate or unclear. So what they say is, you screen the patients. If they belong to very low risk, localized cancer, low risk, Gleason 3+3 killer, we can still wait. If Gleason 3+4 or it is a little advanced cancer, prostate then we will actively involve in the patient care and we'll tell them what are the options we have and we'll choose what is the best for them. So WHO has stated that India must prepare for surge in elderly population. 2019 it is only India is having the highest number of youth force. But 2015 the percentage of people who are going into the elderly population is increasing. So with this increase in elderly population, should we do screening for these patients or not? Yes, we should do. Next. So 5 golden rules. So this is the summary, 5 golden rules. So always you should tell the patient what is PSA, what is the benefit, whether we can diagnose a patient early. If we diagnose a patient early, then we have to do a shared decision making. Whether it is a low risk or intermediate high risk, we have option of any active surveillance or we have option of any surgery or bar radiation. What is the benefit between radiation and surgery? All should be explained. Do not screen men who will not benefit from screening. So patient who is above 80, they won't benefit in screening. 80 years, 85 years, they are not going to benefit. So the life expectancy, if it is more than 10 years, then there is a benefit of doing a screening. If it is already 85, then there is no use of doing a screening at 85 years of age and doing something for them. Do not perform prostate biopsy without any reason. So unless MRI, now the recent thing is MRI is showing that pyroids lesion and so on. So always biopsy should be done with the PSA, rectal examination findings and MRI report. The moon which is the biopsy. Munadi madri transrectal ultrasound, kai which biopsy, no. Only unless it is recommended, we have to undergo biopsy, that is transperineal biopsy. Even the munadiyalla transrectal motion go biopsy pannranga. Because the entire guidelines, both AUA and European Urology guidelines has changed to transperineal biopsy. Do not treat low risk patients. The best way to do this is do an active surveillance. If you have to treat, refer men to a high volume provider. So we cannot go get treated this cancer in small hospitals. So high volume center treatment, you will be having that care, that sort of follow next time they will have that idea. Next. So who should be offered screening for the patients? All men? No. Men who are above 50 should be always be screened. Who are having risk factors, that is father is having malignancy, son is screened for Numa, yes. African American descent, yes. So they should be screened. Life expectancy greater than 10 years, they should be screened. Life expectancy, there is a separate chart. separate chart that is a very Charles index. What we do in Tata Memorial Hospital in Bombay is we will always ask how much your father did, how much your grandfather's brothers. So with that we'll have an idea what is their life expectancy. And patients who request for screening, patients who are having risk factors. So some malignancy is there, so obviously some genetic factors can be there. So patients who request for screening, high risk people you should be screened. And patients who understand this shared decision making should be there always. It's called as smart screening. So this is the next. So this is the recommendation in 2022 guidelines. So men above 50 years of age should be screened. Men with the history of prostate cancer in the family, 45 years. From 45 years they should be screened. African American descent patients, we have to screen them early. Men carrying BRCA genes. This BRCA gene is also important. This BRCA gene is coming up now. So BRCA gene testing. We have seen that Angelina Jolie has undergone mastectomy before cancer came. That also comes under BRCA mutation, BRCA mutation. So patients who are having BRCA mutation. So the next generation of screening will be more into molecular level. So BRCA mutation also they require screening from 40 years of age. So the recommendation is strong. So these people should be screened. Next. Yeah, thank you.
Age should be still reduced from 50 to 45.
Sir, the problem in an Indian setup now, patients they won't have that follow-up. European countries, that follow-up won't be there. So, and when you lose that follow-up, you have that window of curative window. That window will be lost. If our patient if he is having a PSA of 6 and the biopsy shows a small cancer, looks like indolent cancer, and if we keep him on follow-up, we don't know whether it will come or not. And in a medical legal point of view, we don't know whether we are doing it correct in Indian setup. So I think the awareness has to improve, the education has to improve in the particular. I think all of you are educated, you know what I'm talking about. But people who come in a very low economic strata, those patients they cannot understand. And some things are logistically not possible. They cannot travel each and every time, do this. So that is an issue. Screening definitely we should do. Indian population. We are not like an American thing or a European thing where we get all the resources available at any time. So screening has to be done. But screening you have to be in a high volume center, cancer oriented hospital where they will stratify you, keep it in that if you are belonging to a low risk, they should explain, especially educated people, they can keep you on that group and follow up and delay the procedure until. So if you went to a hospital where they are not more into cancer or anything, they won't understand the recent guidelines or the follow-up every corner, they won't know. So that is an issue. So I feel the Indian population will screen but they have to be screened and they have to be explained properly in a hospital where what are the options are available, should we wait or not, particularly in prostate cancer, to avoid overtreatment. Proton
therapy. Whether can be applied for these for early stages at least to avoid surgery, prostate.
Avoid surgery, yeah.
Please throw some light on the proton therapy.
So when you have intermediate and high risk group, low let it keep them on active surveillance. Localized cancer, intermediate and high risk people on the control. If the patient comes, they should understand they have two options. One is the surgery, one is the radiation. Radiation, I'm not talking about proton. I'm just talking about radiation. The most commonly given is chemotherapy. Proton, I'm not talking about the highest. Radiation and surgery are almost equally same. All the studies shows equally same. But each one is having side effects. Each one is having one advantages and disadvantages. I feel as a surgeon, if the patient, my father wants to undergo, he had diagnosed with the prostate cancer, so he's having his options. My rationale of thinking will be, if he undergoes surgery, In case after 1 year or 2 years, if he had any recurrence, I'll think about whether there is any procedure can be done to solve that crisis. That is my idea. If you go for radiation, no, if you give radiation, we have completed the 5 weeks course, you are on follow-up, the first 1 year, 2 years follow-up is okay. Adhikapra is there is increase in PSA, and PET CT shows there is a disease in the prostate. You don't have alternative therapy. It is very difficult to do a surgery. If you do a surgery also, bleeding chances will be more. Not all centers will do. Your continence rates will come down. Chance of rectal injury, motion passage injury is high. Because the entire area will be frozen. You won't have the planes. Other one, if you undergo surgery, my rational thinking, if you undergo surgery, if there is any recurrence, still you have radiation or hormone therapy to control the disease or cure the disease. So that is my rational thinking. If you are asking the proton is having any advantage to the conventional radiation, no. As of now, the study shows no. Conventional radiation is as good as proton. Probably 5 years or 10 years follow-up data on the camera, we can tell whether the complication rates of radiation comes down or not. Proton complications will come here. But oncologically, there is no data.
Without radiation, it was treated with the tablets, hormone tablets.
Treated. It can be treated, sir. Patients who are elderly people, who are not having that much of life expectancy, if you take that, if you do radiation or surgery, there will be a over treatment, and because of the morbidity, they can't sustain the quality of life. Those patients, what we do is we give hormone therapy alone. Hormone therapy alone is not curative, but it will help to control the disease. How many years it can control, it varies to patient to patient.
Yes.
Some patients it can control up to 5 years to 8 years. Some patients they may have hormone therapy resistance. Adiki innor injection or innor tablet or add pannu. Adiki tablet add pannu over 1 year they will be happy. Adikapra if they have any resistance, again we have one more option. Prostate cancer, even in the stage 4 cancer or in the hormone therapy itself, we have lot of options. But patients who are having a good life expectancy, this is not the treatment of choice. This is not. Once if you treat with hormone, if they become castrate resistant, hormone resistant or not, then there is no point of doing radiation surgery.
Because I was given a tablet.
Tablets. So that is also one form of treatment.
Dr. Santoshi was.
When was
he referred to?
When was given, sir?
After a year.
What age? What, how many years back?
Maybe the 76 or something.
So 3 years back or 2 years back?
I got operated on 2016.
Operated?
Yes.
Operated?
Yes. After that, it was not coming down. He gave it to Dr.
So that is, yeah. So it is
After 3-4 times, he said you better consult him. So he gave a letter. You go consult him and he talked. So I went and consulted him. Then he gave me a hormone tablets.
Okay.
Adultron acetate. He asked me to take it. So I was taking it all day. Then used to check it. And I used to take the injection also. It was all done. In 2021, I had a heart palpitation went up. So I was immediately rushed to the New York hospital. They said because of this hormone tablet, I was gone up. So anyway, they called the oncologist and he came. He came and he said, wait. Then he told them to have a gallium 68, After that, he told, because there was a little, it has moved to the, my hip bone.
Mm-hmm.
He said, nothing is there now, everything normal, except, so you stop. Then after, I I got discharged from, I came and told him this is the thing. He said, okay. Then once I told him I'm going somewhere out, you better give me injection, so he gave me. After that, after 1.5 years I am not taking any tablets or injections.
So
Now
prostate-
slowly it is rising up.
So
Last time when I came 3 months back, it was this much better. He said, don't worry, you continue. Like that.
So what we are giving is intermittent therapy for you. Intermittent. We are not putting you on a continuous hormone therapy. Whenever the PSA is rising, we'll give.
If there is any more
Yeah, this is to improve your quality of life. In between, you don't have the issues of palpitations or anything. So that is proven. Intermittent ADT versus continuous ADT. There is a study which showed intermittent up there is no harm.
he says up to 2 or something he told me.
So we physicians will keep on.
Was increasing slowly, gradually.
Which one?
PSA. PSA was gradually increasing. From 0, after operation it was 0.2, 0.25, like nearing to 0.2. Then doctor suggested you go for radio therapy. Till that time the incontinence also was remaining. In about 2 years it was reducing, there was much improvement. Like this operation. Then I had a radiation also, that is after 2 years. After the radiation, the urinary incontinence again increased. So it went back to the, almost radiation last October, right? Now it's almost 1 year. So this urinary incontinence, I'm having it for the last 3 years and still today I'm having it. Does not stop. So this is a constant lifestyle and it's very irritating. I don't feel like going out.
Only surgery alone. When we want to give him radiation also, we won't give immediately after surgery. Even though the PSA is elevating, we'll give hormone therapy. Why? To delay the radiation? Because radiation causes fibrosis in that area. So the continence will be hampered when you give radiation. And the urinary incontinence also will vary from person to person. Some person who we feel when we are operating may not have incontinence in 5-6 months, they will have continence within 3 months. Some patients who we think will have continence, we present good amount of urethra inside, we anastomose it beautiful. Those patients will have incontinence up to 7 to 8 months. So there is a patient variability. The radiation also can cause fibrosis in that area, which causes weakness in the sphincter. So once the radiation was given, usually the continence won't be there like before. Little incontinence will be there, and again some amount of continence will be there, but it won't become 100% normal. So then we have options. From simple options to big options we have. So from penile clamp, simplest option. Then we have slings. Then we have sphincter. Other like options.
But I would like to know from the audience of the world, how long this incontinence lasted in case of Gabon?
This year, February 2020, I have 22 I have done this operation. Prostate. So for after operation, I used this thing for 4.5 months.
4.5 months, when it is stopped?
It does not get some drops or something. It is a negligible or something, you can say. So like that only it is not that much.
Of course, doctor also said in my case it's an outlier. Normally it will stop and then but 3 years I feel it is too long.
So radiation is one of the risk factors. Radiation. One of the risk factors. So that's why we always
the addiction factor.
Yeah, because if you have required the radiation, when you compare urinary control or cancer control, always will be giving weight to cancer control. Cancer control is the first primary goal. Adhikapram the functional control. So if you are in a group where you require radiation, we cannot deny it. We cannot, we should not take, we cannot tell it. So we have to have cancer control. Apart from that, the functional outcome, how much are we able to possible, we have to try. அதில் வந்து the most common thing what we do is physiotherapy and biofeedback exercise.
Biofeedback also.
So அதுக்கப்புறம் there are options like penile clamp. You can come to OPD. Clamp is 250 rupees. 250 rupees. One clamp. We'll tell you how to use it. You can use it and see. Penisக்கு வந்து ஒரு சின்ன stopper மாதிரி இருக்கும். So it has a sponge in between. So we use a clamp. How we clamp, how we hold, if this is the penis, how we hold this, we put a small sponge clamp on top of it. So that won't leak the urine. Whenever you want to go to restroom, you just open the clamp, you pass urine, again clamp it.
No surgery, nothing.
No, sphincter is implantation. Yeah, sphincter is very expensive, sir. Otherwise, you need to implant inside the body. You try this, sir. You feel if it is comfortable. If you are having the troublesome thing, then we can explore other options. Where you say, you come to OPD tomorrow or whenever you come. Monday also you can come. You can meet me or Dr.Manoj Tummala and discuss.
You told me you can continue with biofeedback thing. I will not suggest some other procedure. I don't know what it is.
Sling or
something.
Sling procedure.
It will cost me about 7 lakhs.
Sphincter. Sphincter. Artificial sphincter.
What is it?
It's an artificial sphincter. What happens is if you press the button, inside it will release the cuff. Automatically release the cuff, you will pass urine. After 3 minutes, the cuff will again increase in size. It's a small battery operated, not battery operated also, it doesn't have battery, it is inside your...
That's automatically you have to operate.
You have to operate. You just need to press one
So
small.
there will be some external thing.
It will be inside testis, near the testis it will be.
How much is that operation or how successful is that operation?
That is a good outcome operation.
Next program you elaborate it with the slides.
Let's see.
This is the risky, simple operation.
Simple
Major surgery.
it is a surgery because it involves anesthesia. You need to stay in hospital for 3-4 days. So that is one thing. So not so simple because it involves anesthesia and staying in hospital. The money, that sphincter itself will be expensive. The infection we have to do it very carefully. First in the penile clamp check pananga.
Everything clamp itself you can use it, right?
It is very cheap, very slick. That is effective. Use my paranga. Why don't you try your land and
This is very social life is getting affected.
Then we can start exploring other options. We can explore other options. First we can go to less expensive to more expensive. You start using this clamp, use it for 1 week and see how you are finding it.
What is it?
The clamp use for paranga. Kadikum. Use for paranga. If you are feeling comfortable on that is the easiest way.
It has to be used. Just like you can buy and use it.
Yes, we'll like I'll apply it on you and show it to you. Yeah. You can try that, you can see.
So I'm a physician assistant. So I'm a neurology physician assistant. I've done my master's in clinical psychology. So only to help the people having most neurological causes and psychological causes. So I have trained in it. So what I had idea was as a survivor and warrior of prostate cancer, why can't we symbolize and why can't we have a memory of your fingerprints in that prostate picture? So I had drawn an outline of the prostate and the bladder. So we need your handprints to be printed in there. So just you have to keep your hands in the paint and just keep your hands in this prostate symbol, which I have and this is a bladder and urethral outline. So there are 2 colors we have kept here. So one is yellow, which will indicate this urethral part and the bladder outline. So the prostate will be indicating the red color. So what you need to do is you have to keep your hand on both on the color and apply it to the urethral and wash your hand again and keep the hand again in the red color and just place it in the prostate. So it will be very helpful if you do that, because it is a memory of how these warriors have come across the prostate cancer, and this will be an example for the newcomers who have been newly diagnosed with the prostate cancer.